Hi everyone, in this video I'll talk about another sexually transmitted infection. It is Donovanosis. So Donovanosis is a rare cause of genital ulceration, but should be considered in patients returning from areas where the disease may be endemic, such as in Papua New Guinea, Southern Africa, India, and parts of South America. So Donovanosis is primarily sexually transmissible, but may be transmitted vertically during birth and by casual contact. Donovanosis is caused by a bacterium called Klebsiella granulomatous. Klebsiella granulomatous. The clinical presentation of Donovanosis is mainly relatively painless anogenital ulceration. So it is mainly a type of ulceration or lesions. They're located in the anogenital area and they are relatively painless. So these lesions, they may be mainly ulcerative, proliferative, or ulceroproliferative. Ulcerative means that they are shallow ulcers which bleed on contact. Proliferative means that they're mainly raised lesions with a beefy appearance, while ulceroproliferative is a combination of the two. As for the complications of Donovanosis, extragenital disease is rare, but may involve non-genital mucous membranes. So that is the complication here. So non-genital mucous membranes that may be involved are the mouth, external ear canal. There also could be a hematogenous spread to distant sites, and these sites are the long bones and the psoas muscle. There are also specific complications for males, which are that chronic untreated ulcers may undergo neoplastic transformation, and there is also an increase in HIV transmission risk. In females, there could be contagious spread from cervix to pelvis, which may involve uterus, fallopian tubes, ovaries, and other pelvic structures. Chronic lesions may cause local tissue lymphatic destruction, which causes pseudoelephantiasis of genitalia. Also, there is the vertical transmission to neonates during vaginal delivery. The diagnosis of Donovanosis can be done through histology or NAAT. In histology, the preferred specimen is a punch biopsy of the lesion, which is then formalin fixated. There's also another way, which is through an impression smear, where a glass slide is pressed onto the lesion and then air dried. Sections and smears are Guillem's stained. So histology has low to moderate sensitivity but highly specific. It requires experienced histopathologists, as classic Donovan bodies may be sparse. So the nucleic acid amplification test, NAAT, is done through a dry swab or a punch biopsy of the lesion. It is highly sensitive and specific, but unfortunately NAAT are only available in research laboratories. So the management of Donovanosis, as it is a bacterial infection, involves antibiotics. The recommended antibiotics for Donovanosis are azithromycin, 500 milligrams orally daily for 7 days, or azithromycin 1 gram orally once weekly for at least 4 weeks until complete resolution of lesions. Alternatively, we can also give a course of doxycycline, 100 milligrams orally twice a day for a minimum of 4 weeks until complete resolution of lesions. Some treatment advice is that azithromycin is highly effective and well tolerated, so it is a very good drug for donovanosis. The other important issue is adherence. Adherence to treatment is essential to ensure cure. Consider directly observed therapy. Presumptive treatment should be commenced on clinical grounds while waiting for diagnostic confirmation or if laboratory services are not available. And always seek a specialist advice whenever needed. Other important immediate management: advise no sexual contact for 7 days after treatment is administered. Advise no sex with partners from the last 6 months until the partners have been reviewed and treated if necessary. Contact tracing should be done back to 6 months. Provide the patient with fact sheet and notify the state or territory health department. So finally, for the follow-up of donovanosis, we should review the patient in 1 week. This provides an opportunity to confirm patient adherence to treatment and assess for symptom resolution. Confirm contact tracing has been undertaken or offer more contact tracing support. And provide further sexual health education and prevention counseling. As for the test of cure or TOC, relapse or reinfection occurs and patients should be reviewed at completion of treatment course and at 3 months. Another important thing is that recurrence of lesions may represent development of skin cancer in previous lesions and requires biopsy. As for retesting, it is not required, but it provides the opportunity to retest for other STIs if not undertaken at first presentation. And that concludes this video. Thank you so much for watching. Please like this video, share it with your friends, and subscribe to my channel. Thank you very much.